the CTDI vol based on the 32 centimeter, and that's 5.4 milligray. The parents got the CTDI vol data because that's all that was typically available in the department, and they weren't happy campers. They couldn't understand why their child couldn't have been scanned both days and received a dose of 5.4 milligray. And of course, that's not the patient dose. When an SSD analysis was done at the site, 13 milligray was delivered from both studies. And so the SSDE, of course, is a much better estimate of patient dose. As I mentioned before, there'll be correction factors for heads in the future because heads are based upon the 16 centimeter CTDI phantom. The correction factor will not be as large as those that we find for the abdomen. It's important, if we're going to start applying the SSDE, that we understand the differences between it and CTDI vol. SSDE can be used as a first approximation. Now notice I said first approximation of the average organ dose to the organs completely contained in a scan volume. If I irradiate the abdomen, because the liver as an organ is relatively large and it covers a large cross-sectional area of the axial scan, the SSDE is not going to be a horrible first approximation of the organ dose to the liver. Now, if I've got a small organ located somewhere in the abdomen, the approximation is not going to be as good because we know that the actual dose in the abdomen is changing as we move from the surface to the central region of the patient by a factor of 2 if it's an adult. So the